Setting. So when you first switch on the monitor, the first thing that will come up is it will come up and ask for some patient data, and you can either start a new patient or recall the data that's already in the system. It's asking for the patient's age, height and weight, and the gender as well, and then when you finish that you press home to come back to the main screen. Now we'll stay with the same patient data, but the icons or the interface icons on the left hand side here are the operational icons. If I go into the small medicine cabinet, you'll see it comes up with a list of other criteria here. One is to zero the waveforms. It will not allow you to do anything until you zero the waveforms for the transducers. So we have a transducer for volume view and we have a transducer for the central venous pressure, so you need to zero both of those on this system. Just one important point is you'll need to zero on your bedside monitor as well. Pressing 0 on here will only zero on this system. Once you've done that, you're able to go to the thermodilution icon, which is an indicator dilution. I'll just come back again and show you again. If I go to this icon here, it says thermodilution. Press thermodilution, it comes through with a selection. It says injectate volume. If I press this, it gives me the option of 10, 15 or 20 mils. I tend to start with 15, but the reality is that if the patient's quite small and you're not expecting to necessarily have a very high cardiac output, you could get away with using just a 10 mil bolus. If you have a very large patient that you're expecting to be septic, I'd use a 20 mil bolus because you're going to increase the signal to noise ratio. You're going to make the signal much bigger. And it comes back to your question about 50 mils, where 20 mils is a bigger signal with a cold injectate. You then tell it whether the patient's got a lung resection. The part of the reason you do that is that the indicator time, the transition time, is important for the calculation. And that's why when you do the injection, it needs to know when the injection starts and when it starts to detect the difference. So when you take the injection manifold that we have here, it has the manifold connected to it as a thermistor, and also connected to this port is the central venous pressure. So as we inject from this lumen here, it creates a spike on the central venous pressure which says time 0 is the injection time. It also measures the temperature as it goes into the patient, and then it starts to wash through the heart and lungs. And of course we then tell it whether the patient's had half a lung taken away or some of the lungs taken away, because that would affect the time or the transition time for that indicator. And then it's just simply whether you want it indexed or non-indexed. Then I press start set, and what happens now is it tells me to wait and it gives me an indication, but you can see it's looking for a stable baseline, because any indicator dilution needs to know what the 0 line is before it starts to do an indicator dilution. And it tells me the temperature here is at the moment 23.5, because we're actually got the tip of the catheter in a cup of water. Of course we would normally expect to see that it's normal body temperature, and when it's ready it will tell us to inject. And right now it's done it, it's happy with the baseline, so it's telling me go on up and do the injection. So all I would do now is inject. Thank you. I'm going to have to do a bit of both. Have we got another cold saline?
Just another.
Oh, fine. Okay.
No, actually,
so
it's there. It's there.
So,
yeah, everything connected.
Oh,
you can inject. Yeah.
Okay, fine.
You might want to shut that off though, because it'll piss out.
It'll go flying off the other way. Right. So as I do the injection, I'm doing the right way. Yeah.
There we go.
You can see that immediately it's saying computing, because it's already seen what it thinks is a curve, because we've injected directly into the catheter and it's seen the temperature change. So what this is confirmed to me is, number one, it's detecting the injection point. Number two is it's detecting the temperature change, so everything's working correctly. Of course it will take longer on a patient, but once you've done one cycle it will then wait, restabilize, because in normal circumstances with the patient the temperature would change back to body temperature, and you'd be able to do another injection.
So that would now,
it would come back down, it would say computing, and then it would say stabilizing, and then tell us to inject again. We can go back and review, or I'd normally be able to, but at the moment because of the way we've done this I can't. But if it's come back to baseline I'll be able to review and look at each curve in turn and decide if I need to do more or not.
And how long we have to wait for another?
To be quite a couple of 30 seconds.
30 seconds.
30 seconds, if that, because it returns back to temperature very quickly normally, and then you're ready to repeat the event and then do another injection. But like I said, you can go back and review. So if you've done 3, you look at the 3, they duplicate, then you just say that's fine. take the calculation and use that to do the calculation.
Time we can do inject with saline. If say for example the 3 we've done for some reason they're very different, how many times can we?
You're not defined, so it's very different. So with lithium,
Yeah.
you have a time that you have to allow the baseline to stabilize because lithium stays in circulation and recirculates.
Yeah.
With thermal, it equilibrates very quickly. So within a maximum of 30 seconds, you're back to being able to do another injection. The only thing you'll be thinking of, the only consideration you might have, is the volume that you're giving to the patient if you don't want to give them volume.
Renal
Right?
patient.
Yeah, right. So that's the only consideration. But like I said,
Put them on the filter.
well, you know, bear in mind though, 250 mils is only a cup of water.
for renal patients can be.
Well, yeah, I understand what you're saying, but at the same time, you can
Yeah.
revert to 10 mil injections on this. It actually is still very small.
Would you say, but probably there is no default marker. Would you say we start off with 15, or is it like we have to analyse each patient?
No, it's experience, right?
Yeah.
I'd say start off with 15 until you get experience. When you get some experience with it, you'll be able to look and say, look, this patient's going to be 10. Give them 10, they're a smaller patient, cardiac output's less, we can get away with 10. You could even try 10 first, because it's only saline that you're giving, so it doesn't. There's no risk with trying a smaller volume if you want to.
So if you tried a 10 on the first injection, thought actually that's not very good, I'll up it to 15. Presumably you have to go back and tell it. Obviously
You have to go back and tell it that's 15.
Yeah.
Yeah, absolutely, because the volume is dependent on the calculation as well.
Okay. Didn't call you down much, that did it?
See, there's actually 2 transducers
I
here.
remember you mentioning that.
Yeah. So 2 transducers, which means there are 2 outputs. One goes back to the bedside monitor, and the other one goes back to this monitor. So the green to green is back to our monitor. The red would be the red that you take back to your standard bedside monitor. So that's the first part of that connection. The second part of the connection is the central venous catheter. So if you look at this pigtail at the back, we have green to green, which is the monitor communication back to here. We then have the blue input, which means we take the CVP pressure back to this monitor as well. But of course, then you want a signal to go back to the bedside monitor. So this is the blue to go back to the bedside monitor. So it's just a standard transducer cable that would connect to here and go back to your bedside monitor. So they're the connections. We simply have 2 cables that would come back to here, and then the 2 outputs, CVP and arterial, to go back to your bedside monitor.
Sorry, just want to make sure, where would this connect here?
Same way as you would do a normal transducer.
yeah, okay.
Exactly the same way.
They're going P1, P2.
Yeah, exactly the same way. It doesn't change.
It means that catheter will give us arterial pressure as well.
Yes. So you're just measuring. So this catheter will be the same as you using an arterial cannula on a radial.
Okay.
So it just do exactly the same thing.
It means we don't need another
You wouldn't need a
arterial
radial.
catheter.
You wouldn't need a radial line, no.
Yeah, P1.
And we can take, but we can't take blood for test from there.
Well, there's no reason you can't. Well, I mean, I guess it depends on what you've got connected on the line.
We have
So
to
if you
put
put a
three-
stopcock in there, you could. There's no reason you can't. Because it's still an arterial line. I mean, why the central line? Why are we going for a radial arterial line? A lot of it is to do with indicator dilution, because it's the time of transference from injection to measurement. The other is as well, it's for this particular model is for much sicker patients who can peripherally shut down. And when they start to peripherally shut down, using a radial catheter becomes less reliable. So having a central line with a better signal and a better quality signal improves the signal quality as well in those types of patient group. So you can use this in exactly the same way that you use a standard arterial line. Of course, the only difference is that you're looking after it a bit more.
Yeah, but we still take the blood sample for gas analyzer.
Of course, you need arterial access for that, right?
Yeah.
Yeah. Yes.
So what do you think the problem yesterday was? Is it just a misconnection?
So if there's likely to be a problem, it could be this.
Yeah, but that isn't the case, because there was nothing wrong with that. So is there a way of getting what the problem that we did see by some other means?
So
It's not related directly to that.
Has that been taken out and removed a couple of times? So it actually can be that. So there have been times that that connection, just by removing out, improves the contact, and therefore it clears the problem. So it can be that could have been the problem.
Is that a weak point in the design or
Yes.
currently, yeah?
Yeah, if I had to point to one, that would be it. Occasionally it happens, not often, but then it's just a case of wiggle the connection around, and it sometimes gets that to improve, and you don't have the issue.
So it's the green to green that's the important bit.
Yeah. Well, that's important because that's part of the cardiac output measurement.
But if you look at that and that diagram, it's not clear as far as I'm concerned what needs to be connected where.
Yeah.
That's the issue. That it's easy because they're all the same sort of connectors. You can actually start mixing them up.
Yeah, you're right. That's not.
It's a pretty shit diagram, and it doesn't show the monitor on it.
Yeah.
So you end up with this guy going, oh, where do I connect that to?
Yeah,
That seems to fit on there. I'll just plug it in there.
Yeah.
So better labelling is going to help, and which we can do. We can make some laminated labels for it, I think, so that we make it really clear that that's going to go to the arterial cable on the. That's going to go where it's
Well, it doesn't even tell you here. It just gives you a red line.
I know.
So yeah, I agree with you.
It's
not good.
It's not very good, and it also doesn't show that three-way tap in that diagram. So you've got your manifold here with a temperature port, but you've got that additional bit there before you get to here.
Well,
Unless someone's added that in.
someone's added that in because that's
So that's not part of your set then. No, okay, fair enough. Right. I'll shut up about that.
Okay, no, that's fine. That's fine.
So I saw it set up like this. It's literally been taken off the patient as it is,
Yeah, no,
and
that's
I
not-
assume that's how it came out of the packet. But if that's something they've added in,
Yeah, that's not okay.
fine. That's all right.
And
Hang on then. So, which case? How did they get?
So unless they've got a tube,
Unless
I don't know if
someone's
that's
finding
fixed or
chips
not.
There's not one in there, is there?
and on this diagram, this connection. What
Unless
is this
unless
connection?
it's just that bit there
That goes
that
in.
goes straight on there.
Yes.
And they've added.
Yeah, so they've added that piece in.
Just to see. Is it on this?
Yeah, just push and
Just
twist.
push it on. It's because it's got. Okay, that's
And
now
that piece,
what represents
and
it.
that piece probably this one. No.
No, I mean, to be quite honest, the rule of thumb with this, so let me show you, sorry, I brought some other things as well. So these, they don't come with an extension piece. So that junction here, you can have this one.
So what is that?
That's just one of these. So the injection manifold come as separate packs, so that if they replace this
So what do you get
separately,
in the box when you get it out of the box?
so it comes with everything.
And you can't see.
Oh, brilliant. Well, I mean, that's just the transducer set. So that's what you get in there.
So that is in there,
So you see you've got a stopcock on here. So where you're talking about sampling, and you're connecting this to the femoral catheter, so this would normally have a stopcock on there as well.
So is this included in this?
No, that's your central line.
So that's not something.
That's just on your
that's in
central
here?
line. No.
Oh, okay.
Well, it's part of the pack.
Oh, it is in. Oh, right. Okay.
Yeah.
Fine.
So that's part of the central line. So the CVP, it's in there.
Okay, I'm just trying to work out.
Got the
So you
blades
were fiddling
attached.
with this earlier. What's that do?
That's the flush.
No.
So I was just doing a square wave test.
Oh, right, so you just.
So all I was doing was just checking that I was getting a signal back to the monitor just by flicking the transducer. That's all I was doing.
Okay, so you can do the same with this one,
You
presumably.
could do, yeah. Exactly. So just flick it.
Yeah.
You get exactly the same thing going on.
Must be a useful test as well, because
Yeah.
that means you can actually make sure it's all connected before you start trying to do fault finding.
You can just do that quickly, and I can see very quickly that I've got the right signal coming back to the monitor.
Yeah, but if, what I'm saying is if someone had misconnected
Yeah,
these
yeah.
the wrong
You
way
know
round,
very quickly. Yeah.
then you can spot what's wrong.
Can you show again how to go to that
Yeah,
zero?
of course. So if you press home, anytime you go to a screen, you'll always have to press and go back to home. But if I go to the tools box here, and then it says here it's either 0 waveform and then the injections on there as well. There's some other things here as well, but with this product you won't need to worry about those. It's just these two that are the most important. The reason we've got oximetry calibration if you use a central venous catheter with oximetry, but you're not going to be using that. And also, if you weren't measuring CVP, it's to manually enter the central venous pressure for calculating systemic vessel resistance. But you will be with flow track
I was going to
using it.
say, if you weren't measuring it, how would you know what it is?
You don't, but it doesn't make any
Well, you
difference to the
guess.
calculation. Yeah, exactly. So the calculator, the systemic vascular resistance calculation, is mean arterial pressure minus central venous pressure divided by cardiac output. So when you look at the numbers, central venous pressure of 10 is so small in the overall calculation, it makes no. You know, if you had a, let's give an example, if you had a change in central venous pressure of 10, so it was 10 and it went up by 10, you'd only change the SVR by about 150, so it makes no difference clinically in terms of the number.
Okay, then let's show again. We go to 0. Yeah,
He wants to see it.
yeah. No, I went to
Yeah,
record. Go to 0.
And then you go to 0 waveform. It gives you the option here. You
Yeah,
simply
then we-
open to atmosphere,
Open there.
open the 0 stopcocks, and then press 0 all.
0 all and on monitor as well.
And so
Yeah,
yes,
monitor.
0 all will 0 on this monitor,
Here.
because remember we have two interfaces. We have the interface with this monitor and then interface with your monitor.
Yeah.
So when you press 0, it's good practice to say 0 here and then go on 0 on the bedside monitor as well.
At the same time. Yeah. Okay.
It's just a good practice, not mandatory, is it? Just
No,
to make
you're not forced to, but again, if you're going to 0 one area,
Yeah.
you know, continuity of care.
People might start